Today's episode about eyeballs is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered technology that helps physicians be more efficient and reduce clinical documentation burden that causes people to feel a bit overwhelmed and burnt out. To learn more about how DAX Copilot can help reduce burnout and restore the joy of practicing medicine, stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX.
Knock, knock, hi.
Knock, knock, hi. Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glaucomflecken. This is, of course, your one-stop shop for all things eyeballs. Thank you for joining me on this fine Thursday evening. It's getting kind of late. I'm getting kind of punchy, but we're ready. Let's do it. We got a great topic today, a little bit less intense compared to last week when I talked to you about eye infestations. Thanks for those of you who came back to hear more of what I have to say after that. We're not going to do any of that stuff, all right? We're leaving that in the past, all except for those of you who are still having nightmares. You still have to revisit it every so often. But I'm excited for today's episode. This is going to be great. Before we get to that, the spring conference season has now wrapped up. It's been very busy this year. Lots of events. I got to meet a lot of different people, a lot of different specialties. It's a lot of fun, but it's also kind of tiring. It's exhausting. I don't get to make as many skits as I normally do in the April, May, just because I'm busy doing so many other things. Most recently, I went to the American Thoracic Society. That's right. I was a speaker there. What do I know about thoracic medicine, you ask? Not much. Not much. I think in one of my videos once I mentioned that I didn't quite know that there were two lungs, that there was, one that would probably be enough. But and maybe I made like a unilung joke. I don't know. But that's what's cool about doing the comedy thing and all these different specialties and my medical story is I get to bring it and talk to people that I never would normally talk to. People outside of medicine that do all different things and all different specialties. It really is a lot of fun. But the highlight every year of the speaking that I do is the commencement address. I always do one. Occasionally I'll do two commencements, med school commencements per year. And it is such a special event. This year I went to the University of Michigan. And the reason I did Michigan, I was very excited when I received the invitation because when I was going through my residency interviews for ophthalmology, I went to Ann Arbor, I interviewed at Michigan, and I loved it. It was amazing. The weather was great. The people were wonderful. I didn't go in winter, granted, but it was wonderful. I loved it. I loved it so much that I ranked it number 1 on my list. And then you can imagine how surprised I was whenever I opened up my envelope and I did not see Michigan. I did not match at Michigan. No, that was I matched at Iowa, which I was very happy about. Did not match at Michigan. And so I did what all med students do, right? I celebrated, because I matched successfully. So I was very happy about that. I celebrated, I hugged my family and friends, and then I swore revenge on the program that passed over me, as one does. And I got that revenge. I gave the commencement at University of Michigan. It wasn't revenge. It was all fun. I'm just joking. It was a great time. I am so appreciative of the faculty at Michigan and the students who invited me, and the faculty, the dean who didn't question it, because believe it or not, actually this probably isn't surprising to any of you, I do get vetoed from time to time, and I hear about it. Sometimes I do hear about it. Like I get, the students, a lot of med school graduating classes, they ask for me for a commencement speaker which is always a very thoughtful, wonderful, special invitation to receive. But sometimes the admin, they're like, no, you want who? Glaucom what? What kind of a professor is he? And they're like, oh, he's a private practice ophthalmologist. Like, what? Really? Oh, he's also on TikTok. He's a comedian, TikTok ophthalmologist. I don't think so. No, it's sometimes it's hard to convince people that I actually do have inspirational things to say. I can come up with some inspiration, right? I feel like I'm quite good at it. I've lived some things. I've had some experiences in life that's given me interesting perspectives on medicine, on humor, on I don't know why I'm trying to convince you guys. There's no TikTok commencement address or podcast commencement address. But it was a lot of fun. And I guess what I could do is here for a few minutes just tell you what I told the graduates. Because it's I always have a few life lessons, whatever. It's difficult to do these every year actually, because most of the time my commencement addresses end up on social media, and I don't what I would hate is for the graduates, who most of the med students have seen a lot of my content, to have seen my prior commencement addresses, and I don't want them to feel like they're getting the same thing. So every year I come up with a new thing, new talking points, and so this year the two big things I talked about, three big things. So the first thing was the importance of what it was about surviving residency, how to do that, and the importance of relying on your co-residents, the people in the trenches with you, the people that are going through your basically this shared trauma with your co-residents, and how you need to rely on each other. You need to even do more than just commiserate. You need to talk about real things. Talk about your mistakes. Talk about your surgical complications. Talk about the things you screwed up, that when you got yelled at, and the things that make you feel vulnerable as a physician. Those are the things that you need to be talking with your co-residents about. That's the way you process. And that's the way you learn and get better. You don't hold those mistakes in and let it fester inside of you, because it will, and it'll shake your confidence, and you'll feel like you're a terrible doctor. But then if you talk about your mistakes to the people around you, to your friends, your family, your co-residents, even your attendings, that when you talk about them, you realize that you're not the only person who's ever screwed up in life, and that everybody makes the same mistakes over and over again. Like everybody, hopefully you don't make the same mistake more than once or twice, but the point is, like, other people have made those same mistakes that you've made. I promise, like, whatever mistake you made as a physician, as a healthcare professional, like, there are thousands of people who have made that same mistake. It just happens. These same things happen over and over again throughout history, and we learn from them and we move on. But you don't hold it inside and internalize it as, this is who I am, because a mistake doesn't define you, right? It doesn't define you. So that was one of my big lessons to them. Talk about your mistakes. I also talked a lot about creativity. Obviously, this is near and dear to my heart because of the creative pursuits I have outside of medicine. Although I've just combined it with medicine, so the comedy and the medicine, it's all one weird amalgamation of creativity, whatever. But it's so important, because the in 2024, in today's medical world, the healthcare, medicine in general, it tries to stamp out your creativity. That's what medicine does, because we are so focused on efficiency and standardization and protocols, templates, smart phrases. Everything's about see more patients, but do it efficiently. And so we just, it's so easy to lose touch with our creative selves, our creativity. And so I encourage them that, throughout medicine, throughout your medical career, just keep doing the things that you like to do, that are just joyful, that bring happiness to your life. Whether you make TikToks or you do something more productive or write or sing or dance, whatever, keep doing it. It's just so incredibly important. And it's good for your mental health, and at least in the things I'm doing, like it ends up helping other people. Right. Some of the feedback I get a lot is, since 2020, since the pandemic hit, my comedy has helped a lot of people like get through the pandemic. That's not what I intended when I first started making videos, but it's what ended up happening, which is great, because what good is an ophthalmologist during a respiratory pandemic? There's no other way that I could possibly help people than maybe just making them laugh on a tough day. So the point is, though, those creative pursuits, you have no idea where it's going to lead you and who it's going to benefit. Not just you. It certainly will benefit you, but it can definitely help other people. And then the last thing I talked about was advocacy. All right, this is the first time I really, really dug into advocacy and brought it into the commencement address that I gave this year. And, I tried to be real with the graduates and let them know, because I didn't know until I got out into practice, really, what kind of healthcare system that I was graduating into. We have these grand romantic ideas about what it is to practice medicine and helping patients and looking patients in the eye and just being present. And yeah, you can still do all those things, but medicine, healthcare in 2024 makes it very hard to do those things. And so I talked about the healthcare system. I talked a little bit about what kind of system it is, that it prioritizes profit over patient care, and that they are going to be so instrumental in changing that system. And that, it may not be this year, like get through residency first. That's fine. You got to focus on that for a bit. But at some point, we're going to need your help to change this for the better, for our patients, for ourselves, for our profession. It's a team effort, advocacy. All right, because there's a lot of stuff we're up against, a lot of billion-dollar corporations and other things. So anyway, those are my 3 lessons to the graduates. And so and to any other graduates who are listening, just congratulations. Like I would do medicine over again. Absolutely. I would uh, I would not discourage my children from choosing medicine. In fact, I might even encourage them if they show an interest. All right. I'm not in the habit of pushing my kids to do things that they don't want to do. So if they show interest in it, yeah, absolutely. It's a wonderful field. Like sometimes you lose sight of kind of what you're able to do. Like I'm able to do cataract surgery and help people see better. Like if that's all you can do in your career, that's enough. Like and every specialty has that thing that that you really love to do. I'm not going to give examples for other ones because I'm an ophthalmologist. I don't know anything about other specialties, but that's a lie. I make all these videos. I don't even know why I said that. I just can't think of anything. But anyway, where was I even going with that? I told you guys it's late. I'm a little punchy here. Okay, let's take a break. We'll come back with our topic of the day. All right, here we go. You know what we're gonna do today? The topic has nothing to do with the open. Talking about this is all totally separate. We're talking about eye blood, bloody eyes, kind of intraocular blood, I should say. All right. We've talked about some trauma type things, but there's a couple things in particular that we could go into a little bit more depth about that is maybe not something people think about with the eyes, because you don't think of blood. There's blood in the eye. Well, there can be blood in the eye. You're not supposed to have blood in the eye, but it does happen from time to time. In general, as ophthalmologists, we don't like that. I don't mind blood, but if I could go my whole career without seeing it and dealing with it, I'd be happy. That would be great. But there are some things that we see that are blood related. So we're going to start in the front of the eye. All right, we're going to go front of the eye, back of the eye. So front of the eye, we're going to talk about hyphema. Hyphema. Now, I'm really bad at record keeping, so I apologize if I have touched on this topic already. But we're approaching it from a slightly different context. But you're gonna learn about it again, I guess. I don't know. Hyphema is a great example of a ridiculous word that we have just made up in ophthalmology. Like, what does that even mean? Should should it be called something more related to actual blood? No, hyphema? Hyphema? Like, you keep saying it. It's one of those words you keep saying it, the more ridiculous it sounds. Hyphema. Oh, they have a hyphema. What is that? It's blood in the front of the eye. What? Stupid. That's dumb. We have so many of these examples. Why do we do this to ourselves? Not ourselves. Why do we do this to others? I feel bad for all of you that you have to learn and remember these silly terms, especially you emergency medicine doctors. Actually, you know what? You don't really care. I love emergency physicians. Like, they just describe like what they see. Like, and that's ultimately what you should be doing. Like, you don't have to remember hyphema. Like, what? It's blood in the eye. All right, that's all I have to hear. All right, you see it? Blood in the eye. There you go. Hyphema. I already know what it is. Okay, so hyphemas happen from blunt trauma to the eye. So you get hit with a fist, baseball bat, baseball, softball, whatever, hard object, blunt trauma right to the eye. What'll happen is you get a shearing of some of the blood vessels that are in the angle of the eye. That's where the wall of the eye attaches to the iris inside the eye. That's where your angle is. That's where your drainage channels are in the eye. But if you have a hard enough trauma, it just shocks everything, and you get some like shearing effect of some of those bridging vessels that are in that angle, and they start to bleed into the front of the eye. I'm doing like jazz hands here, bleeding into the front of the eye. Those aren't jazz hands, dripping hands. I don't know what this is. It's like shimmering down. Anyway, so you used to get a lot of blood, and the worse the trauma is, the sometimes the worse the hyphema is. And so whenever the patient comes in after this blunt trauma to the eye, which most of the time, I mean, this is, you see this in all emergency physicians, you know what a hyphema is. You've seen one. It's a really common traumatic eye injury. And so you'll look at the patient. Sometimes you can see it without a slit lamp. A microscope, like a slit lamp, does help. And you see that blood just layering because gravity, obviously, it's going to pull it down. And you just see it layering across the iris. All right, you're looking in the anterior chamber. That's where that blood is filling up. It's filling up the anterior chamber of the eye. And it can be quite severe. It can be really small, like you barely see it, like you almost miss it. It can even be what's called a microhyphema, which is just blood cells that are floating around in the eye. There's not enough of it to layer down, but it's still a hyphema. Technically, it's called a microhyphema. Or you can have a hyphema that's really high and it's filled the entire anterior chamber. Sometimes when that happens, the blood will no longer look red, but it'll start to look black because there's no flow of aqueous any longer in the eye. And so that the blood that's in the front of the eye, the hyphema blood, will start to deoxygenate because there's no flow of nutrients and oxygen and aqueous that keeps that area oxygenated. So the oxygen all leaves the blood and it ends up black. We call that an 8-ball hyphema. That's like worst of the worst. So the biggest danger with a hyphema is high eye pressure. That's the pants patient nature of the hyphema. All right, we talked about pants patients before, right? You remember that? That's when you have a patient that comes in that forces the ophthalmologist to put their pants on to come in to see the patient. That's the definition of a pants patient. A hyphema with high eye pressure, anything over 40, that's a pants patient. I'm coming to see that patient because things can go south very quickly with a hyphema. So here's what you do when you diagnose a hyphema. This is the management. This is the great thing about traumatic eye injuries. It's the same where every single hyphema that comes in, you're going to do the same exact thing. All right. If you're a non-ophthalmologist, here's what you're going to do. You're going to call an ophthalmologist. That's that. First, you confirm the presence of a hyphema. Then you call us. Actually, you know what? Let's do this. Check vision first. But that's it. That's all you got to do. Check vision. Either something on the chart, hand motion, whatever the patient can see. Call us. Say, hey, Dr. Glaucomflecken, I got a patient, blunt trauma to the eye. There's a hyphema, vision's 20/50. And then I'll be like, what's the eye pressure? And you'll be like, okay, hang on, let me go check. You can check the eye pressure too. And you'll come back, oh, eye pressure is 35. I'll be like, okay, great. Let's start some drops. I'll see the patient first thing in the morning. So that's the key. The pressure is the key with hyphema. So for all of you non-ophthalmologists, we always want to know vision with hyphema. We always need to know a pressure. All right. So get your tonal pens out. Do the best you can. Figure out, we got to know what the pressure is. If it's under 40, we can relax a little bit. No one's going to go blind from having a pressure of like 35 for 24 hours. What I'll probably do is have you start the patient on a pressure lowering drop. All right. Like Cosopt. Which is a combination drop, dorzolamide, timolol. The other things you do is tell the patient, you're going to rest. You're gonna be a couch potato. You know what we used to do with hyphemas, like back in the day. Back in the day, we're talking like 20, 30 years ago. These patients used to get admitted to the hospital, and they had sandbags placed on either side of their eye. And they basically just immobilized. And the thinking is that if you move too much, you can cause a secondary hemorrhage. You can make the bleeding even worse. And that has not borne out in the data. So you don't have to do that. You don't have to be immobilized, be admitted. You just have to not be too active. That's the deal. So you're not going out and running a marathon. You're not running anywhere. You're just being a couch potato. All right. So limit the activity. Also avoid any blood thinners. That's big. All right. So nothing that thins the blood. You don't want to take any NSAIDs, no fish oil, obviously no heparin, warfarin, nothing that thins the blood. You want that blood to resolve. And if you thin it too much, you can bleed. And the second time it bleeds is always worse than the first. So we want to avoid bleeding. Obviously, we talked about pressure. All right. You're going to get us on the phone. Let us know what the pressure is. If the patient is at risk for sickle cell, you want to be able to make that diagnosis as well. Because in sickle cell patients who have sickle cell disease or sickle cell trait, they are at much higher risk of having glaucoma from a hyphema. And so we have very low pressure thresholds for taking that patient to the operating room and cleaning out the blood, because sickled red blood cells, they can't be removed by the body's own process. All right. So that's a whole different situation, but we do need to know that. We want to know if the patient's sickle cell or not. And then that patient is going to see an ophthalmologist or an eye doctor every day until that blood is gone. Because again, the biggest risk is that the potential for a second bleed. That's what we don't want. But most of the time that doesn't happen. The patients do just fine. That's hyphema. That's it. Also, you want to be able to look for other eye. If you have a blunt trauma to the eye, you can get a hyphema. You can also get other things. You can get open globe injuries with that. You can get ruptures of the eye. You can get traumatic optic neuropathy. So don't forget, you can get eyelid lacerations from bad traumas, from like car accident stuff. So don't, and this applies to a lot of things in medicine. Don't get blinders on when you see one thing that's wrong. Don't stop there. Keep looking and make sure you don't see other things that could also be wrong. So anyway, that's all I got for hyphema. That's the front of the eye blood. The most common kind of blood you'd see in the front of the eye, traumatic hyphema. There's other reasons you can get a hyphema. You can have a melanoma that bleeds into the front of the eye. You can have a xanthogranuloma that bleeds into the front of the eye. Those are way, way, way rare. way rare. So that's trauma is like 99% of it. All right, let's go to the back of the eye, shall we? Vitreous hemorrhage. That's what we're going to talk about. Vitreous hemorrhage, bleeding into that big old space in the back of the eye. Big old space. You know how much fluid that can fill? About 5 milliliters. It's not much. It's not much space, but it's the biggest space in the eye. The anterior chamber is like 200 microliters. Man, I can't believe I just pulled that out of the recesses of my brain. That is total like board prep, which was like 7 years ago. I'm patting myself on the back here. Hey, it's late. All right, it's like 11 o'clock at night. I deserve a little praise of myself for staying awake. I don't know why. Anyway, vitreous hemorrhage. All right, lots of reasons. I want you guys to think about what reasons you might get a vitreous hemorrhage. Are you thinking? I'm gonna give you like 5 seconds. It'd be easier if some of you were with me. We could like ask you. I could pimp you. I could ask you questions you could answer. All right, here we go. The most common cause of vitreous hemorrhage is diabetes. I bet some of you thought vitreous hemorrhage from a posterior vitreous detachment or a retinal detachment. No, diabetes. Diabetes is a big problem. And so when you have diabetic retinopathy, specifically proliferative diabetic retinopathy, that's the most common because you get these abnormal, very fragile blood vessels that start to grow into the eye. So remember, I had an episode about diabetic retinopathy. You get damage. Diabetes causes damage to capillaries, small blood vessels. So you get all these leaky vessels, and you also, the vessels get destroyed. So the tissue that those vessels supply become ischemic. That's a big problem. That's why people with diabetes are more likely to get strokes and heart attacks and all of because tissue becomes ischemic because you have damage to all of these tiny little blood vessels. Well, what'll happen is your body tries to correct that in the retina, probably elsewhere in the body too, but specifically in the retina, by growing these abnormal blood vessels that are just not real effective blood vessels. They're fragile, they're wispy, they grow in weird directions, and they are very, very prone to breaking open and bleeding. That is called proliferative diabetic retinopathy. That begins the worst form of diabetic retinopathy. So you got to have uncontrolled diabetes, high blood sugars for quite a while to get to that stage. It takes a bit for that to happen. But we see it, we see it almost every day. And when those blood vessels bleed, and they can bleed just spontaneously or from movement. You move your head too suddenly, or maybe you get jostled a bit, or just it can just happen. Most of the time, we don't have there's no inciting event. It just the patient just had an hemorrhage. They woke up with it, or even they were watching TV. Just all of a sudden, the whole world turned red out of the left eye. It's because those little fragile blood vessels busted open, and the whole eye can fill with blood. It can be really significant to the point where patients only see like hand movement. That's how bad these vitreous hemorrhages can be with diabetes. So what do we do in that situation? Well, we do the treatment for that. Basically, what you're doing is you're treating proliferative diabetic retinopathy. And the treatment for that are two primary things. The mainstay of treatment has been laser. So you laser the ischemic retina. All right, that is still a great option. We have good data to support it, that it helps prevent the growth of those abnormal blood vessels because you're decreasing the stimulus from the ischemic tissue for those abnormal blood vessels to grow, right? Because you're just destroying the ischemic tissue. You're not giving it a chance to make the angiogenic growth factors that stimulate the abnormal blood vessel growth. So laser is the mainstay of treatment for a long time. But the more effective treatment now, the treatment that's less traumatic to the eye, is anti-VEGF injections. So that's what we would do. Like if a patient comes in has hand motion vision. The eye is full of blood. You can't even see the retina. You have no view to the back of the eye because you have to be able to see through the vitreous to be able to identify the retina. But if the back of the eye is full of blood, what are you going to do? Like, you can't see the retina. You can't see enough to treat it with laser. What we can do, we know that this patient has pretty severe diabetes and they've had this spontaneous hemorrhage. So what you can do is inject the eye with anti-VEGF medicine that will help to shrink those abnormal blood vessels. Helps those blood vessels to regress. And then we have to just wait for that blood to resolve. And usually it does. It takes a while. And that's the frustrating part. A patient will have poor vision for sometimes 2-3 months before that blood goes away, allowing you to regain the vision. You have better view for treatment. And sometimes that blood doesn't go away. And after about 3 months, you start thinking about doing a surgery to go in and just remove it. It's called a vitrectomy, where you're removing the vitreous and all the stuff in the vitreous, the blood. And so that's also an option for removing that blood from a vitreous hemorrhage. So diabetes, most common. There's other reasons someone can have a proliferative retinopathy. Any disease that results in ischemia, sickle cell retinopathy, that's another one. You can get proliferative retinopathy from that can cause bleeding. Also, another cause of vitreous hemorrhage, I mentioned earlier, posterior vitreous detachment. That's probably the second most common cause, where usually in your 40s, 50s, 60s, sometime in that time frame, the vitreous jelly will detach from the retina. I think I've talked about this before. And it'll kind of pull off of the retina. Well, sometimes it'll pull a little blood vessel and break it open and cause bleeding in the eye. All right, so that's also really common. We see that all the time. The data on that's interesting, though. If you do see a vitreous, like say the patient comes in, they had big bunch of flashes of light and they have blood in the back of the eye. That is what we call a hemorrhagic PVD, posterior vitreous detachment. That patient has a roughly 70% risk of having a retinal tear somewhere in the retina. So be on high alert for a retinal tear, which can progress to a retinal detachment if the tear is not treated with laser. All right, so that's what we're thinking when we see vitreous hemorrhage in the setting of a posterior vitreous detachment, flashes and floaters. A couple of interesting ones. So we have Terson's syndrome. You guys heard of that one? Terson's syndrome? Probably not. Probably why you're listening to this, because you want to learn about it. All right, here we go. Terson's syndrome is when you have blood from a subarachnoid hemorrhage that travels along the sheath of the optic nerve and gets into the eye. This is really, I've seen this once before in a critically ill patient in the ICU, had a subarachnoid hemorrhage and had a vitreous hemorrhage kind of focused around the optic nerve. And that's actually blood that's traveled along the optic nerve and gets into the eye. So it's kind of fascinating. You can also have macro aneurysms. That's something that we see in patients with really high blood pressure. So kind of chronically elevated blood pressure, hypertension. You can get basically just an aneurysm like you get anywhere else, but it's in the retina. So you get this big outpouching of the retinal arteriole, and it's very, very, possible that it could burst. And so sometimes it does, and it bleeds, and you get blood in the retina, in the vitreous. A couple, one's kind of sad one is with child abuse. That is something that we will be consulted for. Ophthalmologist will be consulted for when I saw this, it was in pediatric ophthalmology. So they're the ones that will typically be consulted for something like this. If you suspect child abuse, an exam, a dilated exam of a baby, and then if you look back there and you see both eyes, there's just blood everywhere. hemorrhages in the retina, hemorrhages in the vitreous. It is unmistakable to see that. And when you see that, you kind of never forget it. One of the most difficult things that I've seen as an ophthalmologist. It was during residency. I don't do those types of exams at this point in my career, but it's kind of sticks with you. But it's a very challenging situation, but also it's a fairly straightforward diagnosis to make when you see that, and that maybe there's a few other things it could be, but that's if there's clinical suspicion for something like that, then you put all the pieces together, and that's what you have. So that's another possibility. And there's other random things like certain kinds of uveitis or like inflammatory disorders in the eye, things like severe necrotic acute retinal necrosis, like herpes simplex infections, endophthalmitis, some kind of serious things. But that's the basics of it. So that's it. That's all the blood in the eye things that you need to know about. All right. Go and impress your friends with Turson syndrome. There you go. That's something. I don't know. Remember, the most common cause of blood in the back of the eye and the vitreous hemorrhage, diabetes. You got it. All right. Thank you all for listening. That was a fun episode, right? I think it was. I don't know. I think it was. I don't care what of course I don't care what you think. What are you talking about? Tell me what you think. Leave a review. Send me an email. Tell me how much you love eyeballs because of what I've said. Tell me if you thought about not listening anymore after the infestation episode of eye worms, but you decided to come back because you just love me so much. Let me know. I'd love to hear that kind of feedback. That's great. I'm your host, Will Flannery, also known as Dr. Glaucomflecken. Special thanks to our producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineer, Jason Pertizo. Our music is by Omer Benzvi. Knock Knock Hi at human-content.com is where you can send all that wonderful feedback. And this is a human content production. We'll see you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.